Social justice means applying the law equally to all people. But in practice, that doesn't always happen. I'm John Gonzalez. I'm here with my law partner, Jack DeRora. We practice law. We seek social justice. On this show, we reveal the conflict between the two.
You know, for a while, it was just us in the office over a cup of coffee talking about the news of the day. With social justice issues dominating our culture, our focus became, how do we as lawyers make a difference?
And now it's not just us. Today we have Dr. Abraham Graber to discuss the role DEI plays in public health management, especially in rural America. Dr. Graber has a Ph.D. in philosophy from the University of Iowa. He served as the Director of Medical Humanities at the University of Texas at San Antonio from 2016 to 2021 and joined Wexner College of Medicine in January of 2023. Welcome, Dr. Graber.
Thank you.
Jack, you've no doubt heard that the White House issued an executive order directing federal agencies to stop any and all diversity, equity, and inclusion policies, personnel, position, activities. And interestingly, but probably not surprisingly, the executive order doesn't define what DEI is. There's no definition in the executive order, but it refers to the term over and over again. Help us. What's DEI mean?
I can tell you what it doesn't mean. Well, you know, it's interesting because you're right. The administration has used the term DEI. I don't know if it ever said diversity, equity, and inclusion, but somehow it has been allowed to equate those three words with unlawful discrimination, and nobody has ever stood up and said, hey, wait a minute, the thing you're grousing about isn't part of DEI. And I'm just stunned, at least as far as I can tell, nobody has stood up and said that.
What amazes me when we think about our topic today, though, is how diversity, equity, and inclusion, whether we're going to use the term DEI to mean something totally different or mean what those words really mean, plays a role in getting qualified medical people into rural America. You wouldn't, at least I'd never equated the two as being connected.
Yeah, I agree. When I saw, we can call you Abe, can't we?
Please do, yeah.
When I saw Abe's op-ed, I was stunned because Abe was pointing out, and I'll let you talk more about it, Abe, but Abe was pointing out how if you clamp down on DEI, you're actually going to impede or certainly not help the number of males entering the medical profession who should be going or who we would like to see serve in rural Ohio. That to me was not intuitive. And that's why I said, hey, Gonzo, we should have this fellow talk with us.
So help us understand, is there or was there a problem in rural America recruiting, retaining qualified medical people?
Yeah. So before I start, I just have to say, this is the official disclaimer. Anything I say, it just represents me. I'm not speaking on behalf of OFCU or Wexner or Center for Bioethics, any of that stuff. There's been a really long-standing problem with healthcare access in rural America, and Ohio is one of the places where you really see it. So. There's a lot of sort of causes to the problem, and we can kind of talk about, which any of them that you're most interested in. But one thing that you really see as a really substantial problem is just recruitment of students who want to practice in rural America. So, if you grew up in Columbus and you're used to big cities, the odds are pretty good you're going to want to practice in a city. It's just what you're familiar with. And if you grew up in rural Ohio, it's just much more likely you want to go home and you're going to bring your talents with you. And there are different ways of kind of measuring these sorts of things, but I think probably we are recruiting about half as many rural students into medical school as we would need to fill the gap. So that gives a sense of what that kind of shortage looks like.
Well, that gap is tremendous because there are some counties, like Vinton County, I know from my church, which does work, no hospital in Vinton County. I'm not even sure if there's a single doctor in Vinton County. If there is, it's one or two at best.
Yeah. The dispatch has actually been doing a really good job of reporting on some of this stuff. And there's a county that lost their last doctor in 2024 or whatever. That's where are you going to go, right? I mean, there's not even a doctor. And a doctor is a really far cry from an emergency room, or if you got cancer, you need to see an oncologist, we're talking they don't have a single doctor, much less an emergency room, someone to help you with your cancer, someone to help you with neurological problems, So I think there are, 17 counties in Ohio that have fewer than 20 doctors.
You mentioned emergency medical services. Why did you bring that up?
Well, I think there are really substantial problems with having to drive to see a doctor. So suppose, you have to drive an hour to get to Wexner and you have cancer. That's actually, for a lot of people, just an insuperable barrier. Like, if you can't pay for the gas, if you don't have a car, you're not getting here. But, communities are often pretty good at helping each other out and supporting each other. And so, having to drive an hour to get your cancer medication or your treatment, that's a real challenge. But, if you're bleeding, or whatever it is, if you need to see the doctor in the next 20 minutes and you got to drive 50 minutes to see a doctor, you're just not going to make it, You're just going to die. So, in some ways, emergency medicine there is just a really important thing to be able to access.
It's the stopgap, so to speak.
Yeah, it is the stopgap, so to speak. That's right.
The more specialized, I guess, the medical person is, the least likely we're going to find them in rural America. Again, some of that's just practicalities. There's more people in the cities that have problems like cancer or specialized disease that needs treatment than probably rural America. But what strikes me when we think about DEI on the political spectrum in rural America is that, correct me if I'm wrong, rural America is white America for the most part. And so therefore, if we're not recruiting people from rural America and this results in these shortages, it's actually the white Americans that are probably suffering. Do I have that somewhat correct?
Yeah, I mean, I think when we think DEI, like most things in medicine, it should be data driven, it should be evidence based. And if you start looking at the evidence, see an eye roll there. What a crazy thought, right?
I think that's a word that doesn't appear in the Trump administration. Evidence based. I could be wrong.
But you start looking at demographics and, and who has shorter lifespans, who's sickest. And you definitely see racial lines there. But you also see rural urban lines. So if you look at southern rural counties in Ohio, and you compare them to, northern urban counties, you're looking at 5-year life gap, in terms of life expectancy. Yeah, just based on where you're born,
It's interesting. We've talked a lot on our podcast in terms of Franklin County about how zip code determines your likelihood of good health, success, et cetera. Well, we can expand that, Gonzo. Your county also determines your future.
Well, when we try to get a definition of DEI, you start with the word diversity. And this is what I found, and it kind of goes to what we're talking about. It's a broad range of differences, including race, ethnicity, gender, identity, age, disability status, sexual orientation, socioeconomic background, and cultural identity within a population or workforce. So it could mean just about anything. And if people are against lowering standards to attract a certain race or gender or, person like that, how can you be against, if everybody's on the same plane, getting more people of a certain race or gender or socioeconomic background in a certain field? It just makes sense to diversify a field, right?
Yeah, I mean, I think hopefully by the end we can come all the way around and talk about that question of lowering standards, because I think thinking about diversity in terms of like rural medicine really highlights a key fact about how we should think about the nature of standards, because I think often the way it's conceptualized in terms of like grades and test scores is actually not really the kind of thing that we're looking for. But the DEI is tricky stuff. Y'all cool if I tell you a story about a student I had? He's from rural East Texas. His mom is a drug user. He's raised by his grandparents. He's an EMT out there, and he actually catches the call. So he is the EMT who responds when his grandpa dies. He said I could talk to you all about his case. And, he ends up at UTSA, and he's just very rural, very East Texas, and he wants to become a physician, so he can go back and practice medicine to help people like him. He saw a doctor like 3 times growing up, and they were all in the ER. And I helped this guy maybe for about 2 years after he graduated, and we just worked really closely. And the kinds of things that were getting in his way was like writing a personal statement. There's a lot of things that go into writing a personal statement that are culturally specific, the way you talk about things, the language that you use. I remember having this conversation. He won this conversation, so But I remember having a conversation, and he's going to interviews, and I'm like, look, man, you got to shave that goatee. And he's like, why do I got to shave my goatee? And the answer is that, the people who are interviewing him have stereotypes, and if you're a white guy from rural Texas with a goatee, they're going to walk into that room with expectations of what you're going to be like that might not be accurate. And he got accepted, so he'll be going to medical school, I think, starting in the fall, which I feel really good about.
Nice.
But this is the example of kind of what like DEI should look like, is that people in medicine, doctors, don't come from rural backgrounds, and that means that the kind of standard that they use to judge is often not. A lot of Americans have pretty negative rural stereotypes of rural Americans. Like I always think the movie Deliverance. People think like, what's rural America? They're like, oh, it's like Deliverance. No, that's not true at all.
Who knew?
I'm shocked. So that reminds me, and I don't know if I've told you, Jack, about this. So I went to Marshall University for college, and when I was there, people thought, oh, you're from Columbus, big city, right? And because Columbus was to Marshall. Then I go to Cap Law here in Columbus, and we had a lot of students from New Jersey, New York, and they're oh, this is a cow town. And I really felt I was more like the cow town, because when I went on interviews with the big firms, I had one of those suits that you could turn the vest inside out so it looked like a different suit.
Yeah.
And I didn't fit in at all at the Voorhees, at the Bricker and Eckler's and stuff. I could tell I just wasn't that type of material. And I see what you're talking about, because part of this is I would call it more of an elitist, but I didn't know lawyers when I grew up. Other than the one that represented me briefly for a little issue that I've never talked about. But I really didn't know them. And what you're saying is these kids that don't know doctors, aren't raised even in an academic atmosphere, really don't know what's out there for them.
Yep, and they just don't know how to talk the way that and carry themselves the way that they're expected to talk, and that the other applicants are talking. My mom tells a story, so she's a doctor, and she tells a story about how she went to interviews and they asked her this question, like when you get on the bus, do you have exact change? And she wasn't from a city, like she didn't ride buses, she didn't have an answer to that question. And so all of a sudden, she's not getting into that medical school, but like, did that have anything to do with her skills or expertise or any of that? No, it's these really culturally loaded assumptions that build their way into these. They build their way into test questions. When I write my exams, I work really hard to avoid that. They build their way into interview questions, and getting rid of that stuff. That's just part of what DEI is about.
Well, there's a difference, I think, in how we use the word standard. Let me explain, because I want to attack it because it's sort of the white elephant in the world of DEI. We talk about lowering standards. Now, to me, that means, did this person get the right score on the SAT? Did he meet or she meet certain objective standards? What you're talking about in terms of how people present themselves is equally important. That's standards in a different sense. That's more of how open-minded we are to people who look and sound different. Now, anybody disagree with that so far? Okay, so my question is am I correct that when we talk about DEI, it is not a matter of lowering objective standards or requirements? Do I have that wrong?
Well, all right, let's come back to that question of standards in a second. Because I think thinking about rural medicine can be really helpful there. But, when I think about DEI, a lot of it has to do. So that student I worked with, I mean, he and I met weekly for like a year, maybe 2 years. And it was just constant. And I never, I'm going to be honest, like if he had been a rich kid from the suburbs, I would not have done that. Because I would have felt like he doesn't need that level of support, And so DEI as a faculty member, as someone who goes into the classroom and teaches, it has got nothing to do with standards. And it has everything to do with just making sure that the students I'm teaching are able to get the full benefit of my classroom. So, I was saying earlier, before we got started, I used to teach at Western Illinois University, which was in Macomb, Illinois. So, I'd be late to, class because I got stuck behind a tractor or whatever. I mean, it's super rural. But they also recruited really heavily from inner city Chicago. And when you're thinking about, I had students, this was back when they were calling it Chirac, remember? You don't remember this? Oh, the mortality rate in Chicago during that time period from like gun-related violence. Yeah, it was more substantial than like the mortality rate of American soldiers in Iraq. So I got students who were going home because their friends got murdered, And I got other students who can't be in the classroom because it's harvest season. And if you're not thinking about those different kinds of backgrounds and what you have to do as an instructor to they're all paying the same money, they're all coming to the same class, but they just have different kinds of barriers and obstacles that they have to navigate. And as a faculty member, when I'm thinking about DEI, that's what I'm thinking about. I'm thinking about, what are these students' different backgrounds and what do I have to keep in mind to make sure that I am not, I'm not the thing that's getting in the way of their education.
Well, I appreciate that and commend you. It seems like that should be I was going to say the standard, but there we go, using the word in a different sense all of a sudden. So thanks for explaining that. But I think what the Trump administration sees when it sees the phrase DEI is we're lowering these performance standards. They're not going to be as good a doctor. They're not going to be as good an engineer because they didn't have the right stuff to begin with. So maybe we're conflating terms, but am I wrong that DEI doesn't include a lowering of the objective standards?
Yeah, I think that the key thing is to I think DEI, I mean, honestly, I haven't even used it. I feel like that phrase DEI showed up in the last couple of years for me. I wasn't all of these teaching techniques and thinking about the classroom stuff. I didn't used to go under the name DEI. But, I think that there's a much more substantial criticism of the way that standards are generally conceptualized that's at the root of this stuff. So let's just talk about medical school acceptance, right? Sure. Suppose I know there's a whole lot of doctors who practice in suburban America. There's a lot. Suppose I also know that there are millions of people in Ohio who do not have access to the healthcare they need. Now, suppose I got two incoming students, right? I got to make a choice, It's like, Javier or Alex is going to get in. I'm deciding between the two of them. And one of them is from rural America, but his scores are worse. His test scores are a little bit worse. His grades are a little bit worse. But he's like, look, I want to go back and practice in rural America. And the other guy's got better test scores, he's got better grades, and he wants to go and, work at a clinic in suburban Ohio. If I'm a state medical school, I'm thinking like, hey, I'm funded by the taxpayers, and my job is to train the next generation of healthcare providers. So I ask myself this question: who's going to make the better doctor? Well, we don't need more suburban doctors. We need rural doctors. And so you start there and you ask, are the test scores and the grades the thing that are really indicative of who's going to be a better doctor? And I think the answer is, well, it depends on what the need is. And in this case, the answer is no. The doctor who will better serve Ohioans, the doctor who are going to help the people who need it, the doctor who's going to be the most good, that's the one with the lower test scores because he'll go practice where we need him.
Jack and I have this discussion often about judges. For the most part, all lawyers are trained the same way, whether you go to Harvard or Cap Law, not that I'm on different parts of the spectrum there. But there's a minimum competency, and therefore, when you get to be a judge, there's a minimum competency for judges. And to me, that's okay, because then you can start to think about other differences other than this standard, right? Because it's not always the top standard that everybody has to meet, but there's got to be a minimum competency standard. But the thing with saying DEI is, I go back to, it's really three different concepts, and we kind of lump them in. But what we're talking about is diversity of the DEI, the diversity part. How do we get more of these students from rural America then? How do we recruit them? How do we solve that problem?
Yeah, I mean, I think this is the kind of thing that, if you're going to see strategies that get labeled as DEI, this is exactly what they look like. So, the American Medical Association is really worried about this, and they're asking, what do we need to do about it? And, they think this was like 2022 or whatever, maybe it was more recently 2023. They passed a resolution that's like, look, we need to be getting out in rural communities into high schools, and we need to be recruiting students. This is like targeted recruitment, based on demographic features. That's like a classic DEI strategy, when we're thinking about admissions, we're all getting on towards the point where every 5 years we got to have a doctor, do a somewhat invasive, men after 45 or so every 5 years, I think it's totally reasonable. We're looking at 70%, 60% female doctors coming through the pipeline, 40% men or less. And is it reasonable to want to make sure we're looking more at a 50-50, distribution that matches the population? Well, as someone who's, having pretty intimate procedures every 5 years, I'm thinking I want to make sure I can see a male doctor. It's just more comfortable for me. And so again, I think, in terms of recruitment, in terms of acceptance, I think all of these things push us to think beyond grades and test scores as what counts as the relevant standard. Because what really matters is how good a doctor you're going to be. And that is not something that's measured by a test score. It's measured by the kind of population you're serving, the people you're working with.
It only occurred to me when you said it a minute ago, but these baseline scores that I would imagine conservatives get so concerned about, the premise is the baseline score that they want necessarily determines performance. Mm-hmm. And you're saying maybe not so. There are other factors. So thanks for illuminating that. But here's a challenge, it seems to me, in recruiting in rural America. And tell me how you handle it. If you grow up in Vinton County and you don't see any doctors, you probably aren't thinking it's a possibility for you as a kid to be a doctor. How do you approach that problem?
Yeah, and I'll just say right off the bat, I mean, if you want to look at the DEI literature, people have been talking about that exact problem in terms of race and being a doctor, or just race and going to college for decades, right? So I think you hit the nail on the head. So we have, I think I said this earlier, but it's half as many rural applicants are applying as we need. And those are just people applying. That's not even acceptance rates. So that tells us that, most rural, people in rural parts of the country just don't even view themselves as being able to be doctors. And, you address that, by DEI programs, right? You do outreach. You get in the high schools, you let them know that they're welcome at OSU, but then you make it clear that there's a path for them. And a lot of it's about role models. There's a ton of literature on the importance of role models. So I'm really hoping the student of mine from East Texas, he's going to go practice in East Texas, rural East Texas. And I'm really hoping he'll go by high schools and just give a talk. You see him and he's got his goatee, and he's clearly from that part of the country. And that means the world to students. Okay, he could do it. Why not me, right?
I wonder, because I've been out of academia for so long, do they still have minority grants that help minorities pay for education? And if they do they have rural American grants to help rural Americans pay for it? Because it seems to me that's often a barrier for people, is how are they going to afford to become a doctor? It's not cheap, right?
Yeah, no, that's certainly true. I think we did have grants like that, but it's been the last 3 months. I couldn't tell you anymore.
Right.
Are they all gone? Who knows? Yeah.
What's interesting, too, is that even our federal government and the Trump administration practices diversity. If you think about this for a minute, when the Supreme Court Justice Ginsburg died, female justice, the Trump administration wanted a female. That, to me, fits their definition of DEI. Now, there are hundreds, if not thousands, of qualified female lawyers and judges that can be on the Supreme Court. And believe me, not every lawyer or judge can be on the Supreme Court, but there are a number of them. But not only did he want a female for that position, his first choice was a lady with Cuban background that he was helping, that he thought would help him politically to bring in that vote. So he was looking both at race and gender. He ended up picking
Coney Barrett.
Coney Barrett. Why?
Conservative.
And religious.
And religious.
Religious conservative.
Right.
That is, to me, the epitome of DEI hypocrisy. I'll give you another example that's even more stark, I think. The VA wants veterans to work there, and they have a policy that veterans get the first choice. Now, how do they do that if everybody's equal? They can't, right? So they have an actual law that requires veterans have an advantage in hiring over people who have not served in the military.
I think that has always been the case with federal employment. There's been some leg up for veterans. So is that unlawful today?
Well, who knows, right? But it tells me that this is all a pretext, political pretext is what we're talking about. Because there's nothing wrong with going into rural America and saying we want more people here applying to law school, applying to med school, applying to these jobs where they're underrepresented. Let's go out and recruit them and get, and help them do that. That to me shouldn't be a problem, right?
Well, you would think, but it sounds to me, from what I've been reading, preparing for today, that there's another problem with recruiting people, and that is, you are tending, for the most part, a lower income segment of America. And if you are tending to a lower income segment of America, that affects reimbursement rates.
That's right.
Am I correct, for Medicare and Medicaid? So if that, which was crazy to me, I didn't realize that till I read this. So now you really have to be recruiting people who are ministry-driven more than income-driven. And how do you find those people?
I mean, I think it's under-recognized. So I'm an affiliate member with the Nisonger Center here.
Say that again.
I'm an affiliate faculty member with the Nisonger Center here, which is a university center for excellence in developmental disabilities. So they really just provide support to people who have, developmental disabilities. So like intellectual disability, autism, Down syndrome, that kind of thing. When they bill Medicaid, they expect to get about 50% of what they bill. So if they provide a service that costs $100, they're going to get 50 of that. But then on top of that, the way Medicaid works is that depending on where you practice, they kind of build in this cost of living thing, which means that if you're in rural Ohio as opposed to Columbus, you would get even less than that 50%, which the thing is, this is something my boss likes to talk about. He's got, he's a doctor, MD, and he, has lots of colleagues who sort of are very concerned about work-life balance. And I think he makes them grumpy when he says this, but he's like, well, what if you just go part-time, take a 50% pay cut? And that seems wild, but some of these doctors are making, really substantial money. And so I think, I think you're right. I think you need people who are really ministry-driven, who like that student I had at UT San Antonio, who really just want to go back and give back to their community. And we are talking about a sacrifice of potentially like $100,000, $150,000 a year, but at the same time, they might still be making $150,000 a year. So it is a lot to ask of a person. But I think there are lots of people who are dedicated enough to their community that they want to give back in that kind of way. And on one hand, it is a really substantial sacrifice, but on the other hand, they're not. You still can have a house. You can afford a family, all that kind of stuff.
Well, so we have diversity, and once we get people we need to be in the medical profession that want to be in rural America, then I think that is where we get the equity in the system. Because now the ultimate goal here is to get medical care for people that don't have access to it or can't afford access to it. So if we get these folks and then they're back in that community, then we get the equity and diversity, right? Equity and inclusion.
Agree. But here's my concern. If OSU, as we've seen, immediately acquiesced to this purge of the phrase DEI, then who leads the charge for these rural counties? The AMA is a distant entity. The Ohio State Medical Board is strictly licensing. Who's picking up the slack?
I don't. I mean, the worry is no one. The worry is that Trump administration and SB1 is just it was already a healthcare crisis. I mean, people have been using the word crisis for probably a decade at this point.
Sort of an overused term.
No. I think. Well, I mean, maybe in general.
Well,
but I think.
I mean, only to the extent that we've grown numb to it.
Yeah. I mean, we're talking about a real, genuine crisis. Like in parts of Ohio, the closest maternal, like maternal care, before you have your baby or whatever, 50 to 100 miles. And if you want to talk about how you make sure you have healthy moms and healthy babies, it's not by the care after something gets wrong. It's the preventative care. And we've known that for decades, And so, I mean, it really is a real crisis. And I think I wrote that op-ed in the Dispatch because I'm just really worried that, people are literally going to die. I mean, that's literally my worry. My worry is we don't recruit the way we need to. We aren't taking the things into mind that we should in terms of teaching in the classroom, in terms of who we're accepting. And eventually, if we don't train the healthcare providers that we need, to work in rural America, you will count that in bodies,
Isn't the medical system in rural America even impacted by things we wouldn't associate with medicine, like broadband coverage?
That's a brilliant question. I don't know. I imagine so.
Well,
yeah.
I just know that there are certain counties that have lousy broadband. So you can't, my sense is, you can't even reach people if you wanted to through telemedicine.
No, that's right. Yeah. So because there's this real problem with healthcare providers who want to work in rural America, again, this is probably 15 years old now where we really started pushing telemedicine. So in the old days, you have literally like a hard line, you know what I mean? From
oh, yeah.
Yeah, they put like a hard line out to a clinic in rural America. But yeah, my wife actually, she's a psychologist. She does tons of telehealth. Yeah. And she has clients, particularly in Appalachia, where they can't get in to see a doctor, but they also can't do telehealth because their connection just isn't good enough. So absolutely, yeah.
All those things we take for granted. Gonzo, did you see that letter that was in the Dispatch a couple weeks back by a couple docs at Ohio State grousing about DEI being squashed?
Yeah, when you sent it to me.
I did send it to you. I lost track of that. Well, that's pretty interesting. And I got to believe... there's tension in the workplace.
I'm usually the optimist at the table here. These DEI programs that Ohio State and other schools were doing, they weren't forced on the schools. They came about probably out of a necessity, a need, like we've been discussing here, right? Nobody told, the Biden administration didn't tell OSU to create these programs. But now we've labeled these programs for political expediency as something bad or something good, depending on the side you're on. But they were done out of necessity. And so I think that a lot of schools, such as the Harvards and Columbia, are changing their program, but they're, I think, just changing the words. They're just doing it a different way. I mean, at least that's my hope. What's your sense?
Yeah, I mean, just to speak to that need thing. So here's a statistic that I think can be pretty eye-popping. And you always got to be careful about this because it's not a lot of studies that are published don't replicate. So but supposedly a black neonate, so this is just a neonate, it's just a fancy word for newborn baby, they are twice as likely to die if they're taken care of by a white physician than if they're taken care of by a black physician. Twice as likely. And so when we talk about the need, if you're a medical school, and I think something like 4% of neonatologists, the doctors who care for newborn babies, are black. In America, it's about 15% of the population is black. So if you're talking about need, well, you need to increase your pipeline of black physicians if you care about saving the lives of babies. And I think you're right. I mean, I think programs got created not out of some sort of high-minded DEI concern, but literally babies are dying. Mm-hmm. That's bad. We ought to do something about it. And then I agree, they got kind of wrapped up under this sort of administrative heading of DEI, and that's an easy target. It's much harder to argue we should let babies die. You know what I mean?
Where are all the people, though, that saw, back to what you were saying, Jack, saw the need, knew it was a problem, made adjustments, got more doctors into these areas? Where are they now that Trump is going to putting his foot down on these programs. And again, being the optimist, I think they're just waiting it out.
Well, I would hope you're right, but I think it's more complicated than that. I mean, some of them are probably keeping their heads down because everybody's got to earn a living. But if you recall, we had Arthur James, who is the pediatrician, remember? Well-spoken black doctor, and he was very discreet in what he said about his time at OSU. But I got the sense that his advocacy about the kind of medical problems that you just talked about, Abe, in terms of black mothers not getting the kind of attention that they need as opposed to their white counterparts, wasn't always received positively.
Yeah, that sounds right. Yeah.
And I'm not surprised because I think part of the human condition is we don't like to face our faults, maybe on some subconscious level, but we don't want to hear about that stuff. And again, he was discreet, but certainly that was the inference I drew. And your point about black mothers, I think it was Serena Williams who was complaining about she had some significant problem and the nurse or nurses weren't paying attention to her. And in Serena's mind, it was, I bet if I were white, somebody would have been jumping at the problem. And we also heard that about a black sprinter, same problem. She wasn't being listened to. So there's a lot going on.
Well, we'll have to see, Dr. Graber. It's been 100 days of these new policies, and, who knows what we're going to see, although I think it's a scary proposition in 1,000 days, and maybe we can have you back to see if schools are just changing what they say or actually changing what they're doing, and I hope it's just a matter of words and not a matter of practice. But we do appreciate your insight, and we appreciate you coming in and talking to us.
Yeah, absolutely. Great conversation. Thank you so much. In addition to thanking you, I want to thank WOSU and our sound engineer, Dalton Jones. If you like what you've heard, tell a friend. We want it to be more than us. We want it to be all of us. We'll be back in another week or two with another social justice issue. Until then, so long.